All right. Thank you so much for this great opportunity and welcome everyone. Good morning, good afternoon, good evening, wherever you are. And it's a great time here for the first African Patient Congress. And thank you, Prof, for this great opportunity given to me to moderate and inviting a great, wonderful array of speakers to this wonderful meeting. Thank you so much for finding time. We understand that this is actually the holiday season for our Muslim brothers and sisters, but still we appreciate the fact that you find time to join this meeting. So on this session, the second session of this program, we have two wonderful speakers that will be speaking to us on the dawn of a new sustainable African health care ecosystem, enabling patient engagement and co-creation universal health coverage. So the first person we have to speak is Professor Adenike Grange. She's a former health minister in Nigeria, a great pediatrician and an award-winning great public speaker. So Professor Adenike Grange, thank you so much for accepting to join us. And we also have Fatima Seedat, the South African Depression and Anxiety Group, who is also on the panel. And call upon Professor Adenike Grange, the former Minister of Health in Nigeria, to make her presentation. Professor, over to you.
Thank you very much for that introduction. This is my first time of coming onto IAPO, and I'm very happy to have been invited. My presentation is on patients' engagement as an innovation of maternal and pediatric health. And I would like to say that actually this innovation is not new in maternal and child health. It is supposed to help to preserve, to prevent suffering of patients and to prevent them from having any injury. So I would like to start with two examples that have been that are already in place in the world. These examples are the baby-friendly hospital initiative and the kangaroo care for mothers and newborn babies, the premature babies. These are two examples that started a long time ago, but they have not really been too successfully upscaled because of the fact that the patients themselves have not been properly integrated into the scheme. The Mother Baby Friendly Initiative requires that the entire family be integrated, but so far only the mothers have been integrated, and they need a lot of support. The same thing with the kangaroo, with the baby kangaroo. Now, let me show you the my simple diagram to let you know that the patients in MCH are the population is very large compared to health workers who are actually getting fewer and fewer. And compared to the policymakers, the government, the NGOs, CSOs, and the private sector. So it makes sense to have patients integrated into this and to have them engaged in any venture that is supposed to save their lives. To institutionalize patient engagement and co-creation in UHC, we shall have to use healthy family approach and empowerment. We need to empower both the patients and the healthcare workers. And we need to use the homegrown healthcare innovations and create a supportive framework for both the family and health workers. That was what I tried to show on that diagram. The fact that the supportive framework, if it is not there, the patients are just left at large. And in MCH, the populations of MCH are quite varied. They start from pregnant women to newborn, adolescents, and youth. The lack of appreciation of the size of the population of these patients, clients who have MCH needs is quite notable. The pregnant women are 5% of the population, children under 5 are 20%, adolescents about 15%, and the youth are 30%, making a total of at least 70% of the population. Now imagine if we could just try to include them as patients or clients in co-creation of innovations. It will go a long way towards solving some of the problems of health worker shortage. There's also lack of recognition of the areas where these patients, clients can be engaged and can co-create life-supporting innovations. In MCH, they include shaping and sharing health messages, collaboration with healthcare workers to assist themselves and other patients in the planning and implementation of strategies for improving access to quality, affordable, and culturally aligned healthcare services at the local level. For example, in the provision of prompt access for life-saving emergency obstetric and neonatal care at the one end of the demographic spectrum, to the provision of vaccinations and youth-friendly services across all levels of care from primary to tertiary. There is also a lack of attention to meet these major justifications for promoting partnerships between healthcare workers and professionals at all levels of healthcare delivery in terms of the access to quality and affordable healthcare services. The promotion of integration of services, the lack of transparency and accountability, as well as the difficulties experienced in sustaining the use of innovations. In order to enhance the proposed MCH patient and healthcare worker partnerships, it is necessary to make use of homegrown healthcare innovation and the healthy family approach empowerment with a supportive framework for both the patients and the health workers. I cannot emphasize this enough. The role of the political and professional institutions, the civil society, and faith-based organizations and the private sector in the provision of this supportive framework cannot be underestimated. In the design of this ecosystem, for example, a mix of funding sources such as the Community Health Insurance Scheme will be required, and it will ensure the integration of the conceptual framework into the UHC and SDGs 2030. In conclusion, patient engagement and co-creation of innovations in MCH would result in the following benefits: the expansion in data capture, improved data quality, availability, and use, improved process for tracking investment, expenditure, and progress of outcomes, improved coordination and collaboration of all stakeholders, institutionalization of patients' engagement and co-creation of innovations ecosystem into MCH UHC SDGs 2030. It will also lead to enhanced sustainability and scaling up potential of the innovative ecosystem. However, the main challenge is how to change the perceptions and attitudes of all stakeholders involved in order to motivate them to collaborate and to form the required partnerships. I believe that my time is up, and I would now like to say I thank you very much for listening.
Great. Thank you, Professor. Indeed, with your presentation, wealth of experience. I was like, really, I kept just taking note. I'm just taking note, writing. Thank you so much, Professor. That was great. And we really appreciate the wealth of wisdom and your presentation on this. Thank you so much. So before we go to the session of question and answers, I think we're going to have the presentation from the next speaker, Fatima Seedat. you want to drop the questions in the chat box, in the question and answer column, so that we'll respond to your questions as soon as the presentations are over. So Fatima, Seedat, over to you for your presentation. Thank you.
Don't make noise. Good morning, everyone. I'm very honored to be part of this Congress today. I represent the South African Depression and Anxiety Group, and we're busy discussing a container concept that we've used in our rural areas, which we thought it would be a nice concept and easily adaptable to any setting. So I think the introduction to SADAG would be important, just so you have a background of what we are and what we do. And then, of course, we'll talk about the counseling containers. As you can see, here's a few pictures. Here's a picture of our counselor that is busy assisting a patient, explaining to them what is COVID, especially during this very testing times. It's important to share important information. So who is SADAG? SADAG is the largest mental health advocacy group in South Africa. We do reach out and go into communities throughout Africa. We've helped places like Nigeria, Ghana, Zimbabwe, Zambia, helping them set up programs, assisting them with advice on how to open up helplines, support groups. We've done online trainings with them as well. We host over 30 toll-free helplines. These helplines are throughout South Africa. And in these helplines, what we do is we do a quick telephonic counseling session with people that are not well, people that require assistance, people that are feeling overwhelmed at a certain point, or they just need some advice on how to receive mental health assistance, and also basic counseling, which we offer. With mental health, we all know that it's one of the most under-resourced health sectors in probably the world, and it's always overseen by other CDCs and stuff. So we don't get so much funding. Also, the fact that resources are very few in Africa, so we don't get, we have very few psychiatrists and other professionals that are able to assist people far-and-wide. A lot of our rural communities do not receive the help that they need. So we were inspired, the founder of SADAG was inspired to help people, just to assist them, taking them you know, through the process of receiving the proper help that they need, because it's much needed in all our communities. We also do a lot of support groups where we train people on how to just create a safe space for people that have been diagnosed with mental health and they need to maintain their well-being, so they have support groups that they can attend. We do a lot of trainings, school talks. We create a lot of awareness around mental health again. We find it really important to assist people understanding what mental health is, and also trying to just know how to help people if they do come across someone that needs assistance, and obviously then refer them on to us, our toll-free lines, and we can take it from there. Corporate wellness is also a very important integral part. There is no well-being if mental health is compromised. If you have any mental illness, it does affect your functionality, it does affect your daily activities. Therefore, SADAG tries to advise people and to encourage people to take care of their mental well-being, so that they are able to function and they are able to live a very functional life as well. So corporate wellness, we go into companies, businesses, and we assist people with that. Our awareness program is also very innovative, because we feel like the more information we get out there, more people are able to understand what mental health is, and more people are able to identify mental illness, or are able to receive the help that they need through our presence on social media, in press articles, on TV, on radio. We try and go far and wide to reach everybody. The whole presentation is about our rural outreach programs at the moment. So I think we can go further. So what we've done is we've realized that in our rural communities, it's not easy to receive mental health services. There's a lack of it in communities, and also it's very difficult to get the help that is needed, and also people don't understand how to receive the help. So what we've done is we've created, we've taken a normal shipping container and we converted it into an office, and therefore people could come and visit us and try and receive the help that they're looking for. So the setup of a container is, it's a lot of thinking goes behind it, because you have to think about the area that you're going to target, how much of a need it is for so we do area assessment of what the need is for the container. Thereafter, we do a land assessment. So we communicate with councillors and people that are in charge of the area, find a nice place to put in our container. Then it's the whole setup about, creating the office space, doing all the background maintenance work. When we're done with the setup, we do recruit. So whatever we do with the container, we try and recruit help and services from people in the community, which creates a nice ripple effect. So we're creating job opportunities for people within the community, which is nice, because in most cases, people aren't working or unemployed, but they have the skills needed, so we do use them. When it comes to people that are working within the container, we recruit counselors or people that are able to assist a community. So what we do is we send out a notification, people then respond to it, send us their CVs. We have interviews with them, a normal recruitment process. But thereafter, we do an intensive training. So training lasts for about 2 weeks. We teach them about mental health, all the different aspects of mental health. That's depression, anxiety, panic, substance abuse, and everything else that they need to know about mental illnesses. We then train them how to do mental health first aid and basic counseling skills. And thereafter, our team is ready to then start counseling. Once they are ready to start counseling, we start getting our patients in and we start giving free mental health services. We also go out into the community. We go to do talks within churches. We try and create networks within a community, because in most cases, the community or the people within a community know that they may have a problem, but receiving the help becomes really difficult. What happens is they're not so sure which hospital to go to or which clinic or how to get help when they reach a clinic or hospital. So what we do is we do the initial assessments, we see what the needs are. Thereafter, we create a network with hospitals so we can streamline the process of people receiving help. So when they go to the hospitals, we do notify the head psychologist, psychiatrist that we are referring patients on. Could they please assist? At some point in our Deep Sleuth container, what has happened is we've created a good network. So we start creating appointment bases with psychologists and psychiatrists in the local hospital. We do also work very closely with traditional healers. We feel that it's essential because traditional healers need to know about mental health, but also to assist people with mental health as well. The impact of community, the impact and reach within a community reaches so many people. The one container that we've placed into Deep Sleuth has now been recognized as the blue container, where everyone can receive assistance and help. At any time that we are open, people come for anything, whether it's legal advice, HIV advice, you name it. People feel like it's home. We've done a bit of research within our counseling container in Deep Sleuth. So we service an area population about 350,000. From there, we've established our 2 offices with 2 counselors doing face-to-face counseling on a daily basis, Monday to Friday. We've taken 186 patient reports, and we've done a mini research project on it just to find out how effective the program is. The ages that we've seen range between 10 to 86. If you're wondering why so young, we do school talks and kids do come through and ask for assistance. The area has a lot of traumatic events that happen on a daily basis. So you hear about rape, you hear about theft, you hear about robberies. It's a very, very troubled area. So we try and assist as much as we can. Obviously, the gender, females are more able to open up and speak about what they're going through mentally in comparison to men. That's why there's such a big difference between the two. On our initial appointment with a patient, usually it's a walk-in and they just on a first-come, first-served basis. 77% of them were extremely distressed, or they felt that they really, really were not doing too good. But over time, when we did a follow-up call and a session with them, 25% only displayed the highest distress levels. But that's because of the area and how difficult it is to be living within that area. The types of problems we received were stress, anxiety, domestic violence, substance abuse, PTSD, trauma, grief, suicidality, and HIV and AIDS. It's a variety of stuff. A lot of people come in for a lot of things. At times they do ask for legal advice and we refer them on. And that is what we do is we try and create networks, as I've said before. Therefore, we have a big referral base, so we can send people over to different streams of help. The effectiveness of our program, 99% of patients have expressed that they are happy with our services. They do have a continuous visit to our container for their support groups so that we can help them maintain their mental well-being as well. A lot of them, we've tried to encourage them to do a veg garden, which is another initiative that we do with our patients within the area. So basically, the container is like a little mini innovative way of providing services where there are no services at all. And a lot of people could adapt the idea of it and put it into their own perspective and in their area of expertise. It's just a nice way to reach out to people that don't have the help that they need and they are desperate. This is the end of my presentation. I'd like to thank everyone. It's this beautiful staff of ours. Thank you so much.
Thank you so much, Fatima Seedat. Beautiful presentation on mental wellness. I quote one of your statements, there's no well-being if mental health is compromised. Absolutely, I totally agree with you. And that is really great work you're doing in helping to maintain mental wellness of African patient populations and Africans as a whole. So thank you, Fatima Seedat. So participants, once again, good morning, good afternoon, good evening from wherever you're joining us. And if you're just joining us, we've just had the presentation from Fatima Seedat on mental wellness. And before her, we had Professor Adenike Grange, the former Minister of Health in Nigeria, who made her presentation earlier on. So we're looking at the dawn of a new sustainable African healthcare ecosystem. And what we're looking at is enabling patient engagement and co-creation in universal health coverage. And we all know that universal health coverage is built on in the context of healthcare for all, so that nobody faces challenge in accessing the health that they need. So it is now time for questions and comments, questions and answers. But before we go on to questions and answers, I just want to go back to the presentation made by the Professor Adenike. You mentioned something that is really so key, and lack of recognition of areas of patients' expertise in planning and implementation of strategies in the healthcare services. I just paraphrase it. Prof, can you tell us from your own experience of a Minister of Health, what do you think are the challenges around the lack of recognition of areas of patients' expertise in co-creation and the delivery of healthcare services, especially in African region? Professor Adenike Grange.
Thank you very much. I believe that it's a problem, it's a human problem. People do not want to change the way they think of other people. We have always given a top-down type of service to patients. And it's actually easier to give top-down. You know, if you want to engage patients, you need a bit more time to be able to explain everything and get them to come along with you. And so it's been a problem that has existed for a long time, and it will therefore need a lot of effort to change through training of health workers, training of policymakers, training of civil society organizations, etc., to try and recognize the need to empower patients to before they can become engaged. They need to be also to be trained. So that is part of the empowerment, and as I said, it does take time. But we have started, and I gave those two examples of our attempt to get patients engaged. The baby-friendly hospital initiative, which you know about, which has to do with breastfeeding, and it's taken a long time for us to get mothers to change their way of breastfeeding babies, because they always thought that they knew how to breastfeed babies. So why do you want to come and tell us how to breastfeed babies? But because of the scientific evidence, which we had to present in a simple way, and also we needed to give them the support before they could accept the strategy of optimal breastfeeding, which is to breastfeed alone for 6 months, and then before adding any complements for 2 years. So it's those are issues that needed to be teased out with the patients themselves, and before they could be engaged. The other example that I gave is the kangaroo baby care, which helps to give warmth to premature babies through a skin-to-skin contact with the mother. And again, it's a new concept, innovative. It would have been better if they had co-created it with us. But the premature baby is very, very delicate, and usually people don't even want to handle them, So then when you say put the baby close to your body, it's a very new concept and frightening to them. So we have to go through the process of educating the patients before they can accept. Yes.
Good. Thank you, Professor. A follow-up question to that. From the benefit of you being the Minister of Health in Nigeria, and now with your level of with the expertise, now around the room we have patient advocates, and we're talking about co-creation in the health ecosystem. In what ways do you think are the best approaches patient groups or CSOs should adopt in knocking on the doors of policymakers to have this change in this paradigm shift? Because patients are seen as outsiders in their own healthcare. So what approaches do you think, what strategies do you think we patient advocates could adopt in convincing your colleagues who are there in the policy, in the ministries, to bring on patient engagement and co-creation in the health ecosystem? Thank you.
In healthcare, we are always looking for evidence. And I believe that the models that show better outcomes by including patients in taking care, in co-creation of innovations and taking care of themselves, would help to convince. But it takes a long time, but definitely we do have to build models with evidence-based data. And also, of course, we shall now have to integrate it into training programs of health workers, of all health workers and health professionals. So it's a long road, it's a long journey.
Yeah.
But I'm excited.
Thank you so much, Prof.
You have decided to take it up. The reason I got, I really wanted to be involved in this. I remember telling a colleague of mine, BC, that, I think that MCH is relevant here. It's because, for a long time we have been, trying to get this baby-friendly hospital initiative going and all that. Yes, it's going, but it's not as fast as it should be if everybody, if all the health workers realize that, the mothers have a right to be supported. It is their right to be supported. Usually that support is given as, a privilege rather than a right, but it is a right. Then maybe we need to adopt a rights-based approach when we are trying to engage patients.
Thank you, Prof. Fatima said that you made a beautiful presentation on mental wellness and great, wonderful work you're doing in South Africa and across. And you also mentioned in my country, Nigeria. Beautiful, great work. Now, how would you bring on patient engagement and co-creation in delivering mental wellness programs and in driving advocacy towards improving universal health coverage in the context of what you do? Fatima said that. Thank you.
Thank you so much. I think it's so important that we educate people. So I feel like education is the most important thing to attain a goal that we need. And right now at SADAG, what we do is we try and spread enough information and advocate for mental well-being through that. So we do like information sessions, we do webinars, we do Facebook Lives. A lot of our youth today sit on social media. So we target them as well. We just want to, spread the message far and wide. Our social media is the most important space that we use to get information out there. And that is how your beautiful country, Nigeria, even contacted us, an organization from Nigeria. During, trying times, they felt like they needed to do more, help people with dealing with the trauma that they're going through. So for me, education is so important. And the more we spread information about what we greatly feel passionate about, for us, it's mental health, the more we share the information, but in basic, simple terms where people are able to comprehend and understand the concept. That's the most important thing for us. But yeah, I think that's something that's vital for all communities, for all. You can use the idea throughout your whatever you're working on. Just spread as much information so that people understand what mental health illness is, and then also where to receive the help. Because like I said, what we do is we spread the information, but then we redirect them to us so we can help them when they need the help they need, so that we can direct them into the places where they need to receive the resources. There's not much resources in Africa to receive a lot of help. And we always have like maybe one psychiatrist to a community of maybe 1,000 people. So what we try and do is we try and streamline it so that people are able to get the help that they need.
So sincere apologies, participants, sincere apologies to everyone. We're internet challenge. And so Fatima, when I lost internet, so I lost traction on what actually you are saying. So do you want to, do we have a question, but do you just want to kindly just give a brief summary of what you just mentioned in regards to the question I asked you?
Okay, so I've mentioned that education is key because of the lack of resources in Africa. I think the more people that we educate about a specific subject, like in my case, it's mental health, the more they understand it better, the more they'll understand where to get the help they need and where they are able to reach out to. They are also, I think one of the important things is that we also need to give them a place or space where they can receive the help. Like for instance, in South Africa, with us in mental health, we redirect them to our toll-free numbers, to our WhatsApp lines, to our SMS systems, to our emails, so they can reach out to us, and thereafter we can then help them receive the help that they need. So because obviously over time we've developed a referral system, and with that referral system we are able to send people even in the rural communities to a place where they can receive the help that they are in need of. So for me, I think the most important thing for advocacy or for patients at large is education through every sort of space that we are able to use. So I'm talking about social media and our normal media as well.
Thank you so much, Fatima. Thanks so much. Quite a beautiful presentation. Now we have a question from someone, and the question is that how could healthcare providers in high economic countries like a pediatrician in Netherlands, Professor Adenike, I believe probably this is a question you would like to respond to, support the middle and lower economic countries in Africa? So this question is from Liesbeth Sederius. That how could healthcare providers in high economic countries like a pediatrician in Netherlands support the middle and lower economic countries in Africa? Professor Adenike Grange, probably this will be able to respond.
Well, thank you. That's a beautiful comment. We are always welcome help in Africa. There are, well, several ways that you can help. One of them is by working through one of the major NGOs that they're already established in the various countries of Africa. But if you would like to work directly with a group in Africa, then obviously you will have to identify that group or an institution or whatever, and there will be dialogue between you and the institution. And you know, it's very possible that you can come to an agreement to fund a project of common interest. But quite frankly, the projects that we prefer to be funded will be community-based projects, you know, because this is where the lack is in terms of funding. And I was going to mention that one of the problems that we have with funding projects at the community level is because of the way the central government budgets and releases funds. You know, there's budgeting for big projects, and then, you know, the resources need to go down to community. By the time they get to the community, it's really quite a problem to account for it in terms of aligning the money to specific patients or specific, you know, somehow I've never really understood why budgeting can be so much in bulk at the central level, and then to translate it into to help individual patients or groups of patients becomes quite difficult. So we do need some financial, we need support of economists there, you know, because the NGOs, the big NGOs manage to do this. So it's important that when you do want to help, you need to know how the money is being tracked, and whether it is being used for the purpose for which it is intended.
Now, one challenge again, Professor Adenike, and I believe Fatima will also probably agree, majority of community-based groups and NGOs in Africa mostly receive just peanuts compared to the bigger NGOs. And most of this work is done by the community-based groups. So that is one big challenge patient groups and other organizations might face in Africa. Fatima, do you want to respond to that?
Yes, I think our NGOs always try our best to receive the help and the funding that we need. I mean, in the trying times of COVID-19, a lot of funding has been taken away from a lot of us. Big NGOs and even big NGOs like us in South Africa, we're not getting enough money to keep us going through the months. We've seen an increase in our toll-free lines, people calling more. That means phone bills are exceedingly more expensive than what they were last year, 2 years ago. Ever since the conception of COVID, we've received almost triple the amount of calls we usually get on a normal daily basis. So from getting maybe 400 calls, we now on 1,600 calls a day of people asking for help and services. Those expenses are just too much for us. What we need to do is maybe, get a community together, people in big corporate companies and corporations to assist in small projects and programs that we run in. But to get the buy-in is also really, really difficult at the moment.
All right. Thank you. Dr. Elizabeth Onifade, probably sounding Nigerian, is asking this question. Do you think healthcare training institutions have a role to play in this cooperation, this new approach to patient engagements? So could they, for instance, review the curriculum? That is a question from Dr. Elizabeth Onifade. Professor Adenike Grange, as a policymaker, and now I'm happy that we are winning you over as a patient advocate for patient empowerment. So how can you respond to this, Professor Adenike? Thank you.
Yes, definitely. I would like to respond to Dr. Onifade's question because it's a very good one. Yes, the process of getting any project to be sustained is to ensure that whether it is sooner or later, the principles of managing such projects are incorporated into the curriculum of health workers, and they are taught clearly so that they can apply them at the community level. Our problem is how to get that transition. So it seems that you cannot jump over certain steps. We need, first of all, to create evidence in the community that something works, and then carry it to the professionals and convince them to include it in the curriculum. But definitely, it has to be. I'll give you an example. The issue of oral rehydration therapy started in the community, but gradually we managed to get it into the curriculum of nurses, of medical students, of postgraduate students. But by the time we engaged them, we had to buttress those principles with scientific evidence. So, it's definitely.
Thank you, Professor. Yeah, yes. We have just barely 3 minutes to go. So Fatima Seedat, one last word. What would you say is your recommendations in building this enabling patient engagement and co-creation in the context of universal health coverage? So one word from you, Fatima Seedat, as your recommendation. Thank you.
I think the most important thing is, firstly, patient education. Secondly, training of people that are based in communities to then render services and help in communities, because that would be the easiest way to access any type of help that people need. And I think the third thing is, obviously, we all have to really work very hard to get buy-ins from different larger entities so that we can then create more resources for people in areas where there is no help or there is no resources. If we could get, ideally, as SADAG, if we could get a corporation that could provide financial assistance, opening multiple containers in all different areas, we would definitely be on it, because containers are so effective, and the counseling that's provided within there is something that's really important for many people. So that's my final few words. I'd like to thank you.
Thank you, Fatima. Fatima, thank you so very much. Beautiful recommendations. Professor Adenike Grange, the great former Minister of Health, Nigeria, from the benefit of insight, and what you have seen now outside the government, if you are given the opportunity to say this is what you would do as a policymaker in government, what would be your recommendations towards improving patient engagement in co-creation in the context of universal health coverage?
I believe I would like to encourage the formation of partnerships and to coordinate the various projects that are in the community, with partnerships between health workers and the patients, and partnerships among the professionals themselves. You know, without that kind of coordination and collaboration, among all the stakeholders, I think, we may not achieve our goal. Having said that, I want us all to believe, to know that we are all potential patients. So it is in our interest to make sure that patients are well treated, and they are recognized as partners in the management of their illnesses. Thank you.
Thank you, Professor. And to just build on what you just mentioned, the challenge we've always had is that majority of health professionals or policymakers see patients as helpless people that, are lacking expertise or lacking skills, and people that are just helpless, and so without little or no contribution to the healthcare system. I am a patient myself. I live with hepatitis B, and it's something I've lived with for several years. So patients like us need to be engaged, need to be on the table to make decisions about our healthcare and to drive the ecosystem through a co-creation process. And that is what this has been about. We're talking about universal health coverage. When we say healthcare, people should access healthcare that they need without facing so much financial challenges, cannot be achieved without the engagement of patient groups. So thank you so much to all the panelists. Thank you, Professor. Thank you, Fatima. Thanks a lot for your beautiful contributions. I hope that this will contribute towards capacity building and also helping our patient groups across Africa and across the whole world to see themselves as equal partners in delivering healthcare services. So thank you once more, IAPO, for giving me the opportunity to moderate these sessions. And with this, we draw this session to a close. Thank you so much for being part of this. Thank you.
Thank you.